Hello, good afternoon, doctor. Can we start the session?
You can start your session.
Okay, doctor, thank you. Dr. Anna, is there? Hello. Can you please present your presentation?
Yes, I'm having a bit of connection issues. Just a minute.
Okay.
Hello, am I audible? Hello.
Yes, ma'am. You are audible.
Shall I start?
Yes.
So I'm here to talk about a case of xanthogranuloma of eyelid in a young adult. So a 15-year-old female presented to us with the complaints of a painless pea-sized nodule 2 years ago when she noticed it first. She underwent excisions for the same, the details of which is not available, and the swelling recurred and it was painless and gradually progressive in size following which, but she did not seek any medical attention due to the COVID scenario. But finally, it started obstructing her vision and it was cosmetically uncomfortable. The size was about 1.5 centimeter to 1 centimeter in size, firm nodule with no signs of inflammation. Overlying skin was not pinchable and it was a no mobile mass. It was involving the lid margin, about the middle one-third of the lid margin, and involving large follicles as well. This patient was managed surgically by excision biopsy with clear margins and primary closure. As you can see in the picture, the suture material used was 60 micron. The lid margins were opposed with minimal notching. Long sutures were left at the lid margin and taped onto the lid to avoid foreign body sensation and corneal abrasions. Post-operatively, she was told about chances of recurrence in tropion.
Ma'am, your audio is mute.
You are not audible, madam. You have stopped your presentation.
Doctor, can we move next one?
You can go to the next person, but what about giving marks to her? No, it's not complete, no?
Yes, doctor. We'll wait 5 minutes more. Is it okay? Okay, okay, doctor. Thank you.
Hello, Madhav madam.
Sir, let the another speaker start, sir.
Yeah, that's what. Let the other free paper. Let them start.
Once she is
Second
ready.
or third, whatever. Yeah, go ahead with the next paper. Free paper.
Dr. Anush, are you there?
Good afternoon, ma'am. This is Anusha.
Okay.
Can I start my presentation?
Yes, ma'am.
Is my screen visible?
Yes, ma'am. Visible.
Very much.
Good afternoon, everyone. Today I'll be talking about a study, Transcaruncular Modified Medial Orbitotomy, a globe-sparing intervention in management of COVID-associated mucormycosis. The outbreak of coronavirus disease has spread rapidly on a global scale. Along with this, there was an abrupt increase in the number of mucormycosis cases. This entity was termed as COVID-associated mucormycosis, that is CAM. India had been gripped by a notoriously fatal disease, ROCM, that is rhino-orbital cerebral mucormycosis, and the first case was reported in February 2021. The main aims of the study were to describe a novel method of transcaruncular medial orbitotomy, local debridement, and amphotericin B irrigation into the orbit for CAM cases, and evaluating its outcome in controlling the disease, increasing the survival rate, and as a globe-sparing intervention in patients with localized orbital involvement. It was a prospective interventional study conducted between May 2021 and July 2021. The sample size was 10. Patients included were COVID-associated mucor patients with medial and inferomedial orbit involvement with negative perception of light. And patients with minimal orbital involvement were considered for TRAM. Patients with extensive disease involving apex were considered for exentration, and patients not consenting for the procedure were excluded in the study. A multi-speciality evaluation was done, including a physician had examined the patient for diabetic status, nephrologist in view of starting and monitoring systemic amphotericin B, oral and maxillofacial surgeon to evaluate the palatal involvement, ENT evaluation for direct nasal endoscopy along with nasal swab and scraping collection. This collection was sent for KOH mount. Ophthalmic evaluation included visual acuity assessment, pupil reaction, slit lamp examination, fundus examination, along with ptosis, proptosis measurements, and ocular motility measurements. Investigations included diabetes, HIV and HPSAG status, and COVID-19 alarm markers. Coming importantly to the radiological evaluation, here MRI imaging of the paranasal sinuses with orbit and brain was done, and the MRI showing increased tissue contrast and loss of contrast enhancement was localized to the medial inferomedial compartment was considered. Here in this image, we can see the MRI. In the left side, the medial compartment is involved. There is loss of contrast enhancement. So the procedure, transcaruncular modified medial orbitotomy was done. It was done under general anesthesia along with the procedure of FES. So the first step was a 180-degree medial conjunctival peritomy was done, and a perpendicular cut was given to reach the plica semilunaris. And further medial orbit was reached. The necrotic tissue was debrided and sent for histopathological analysis. And in cases where clinical evidence of inferior orbit was noted, an inferior conjunctival incision was taken and a necrotic tissue was debrided from that area as well. Intraoperative amphotericin wash was given to the orbit and sinuses, and finally the sinuses were packed. Towards the end of the procedure, a 26-gauge scalpel catheter was taken and its needle was dismembered. The new end was given multiple vents and it was placed deep inside the medial orbit, which was used to give amphotericin irrigation post-operatively. And it was sutured to the adjacent skin using 4-0 non-absorbable suture, and conjunctiva was closed. So here we can see in the first image, number one, it shows 180-degree medial conjunctival peritomy with a perpendicular cut, and two, it shows the scalpel catheter placed in the medial orbit. And post-operatively, 3 ml of 3.5 milligram per ml liposomal amphotericin B irrigation was done along with nasal suctioning. And intravenous liposomal amphotericin B 5 milligram per kg per day was given, and adequate glycemic control was maintained. So this is a small video of the procedure. Conjunctival peritomy along with the perpendicular cut. The necrotic tissue was debrided from the medial orbit. It was done until fresh bleeding was noted. Finally, the conjunctiva was sutured and the catheter was placed in the medial orbit. Post-operatively, amphotericin B irrigation was done via the catheter. So age group of the 10 patients ranged between 34 to 72 years with a mean age of 49.9 years. And all of them had unilateral orbital disease involvement with no perception of light in the involved eye. So among the 10 patients, 7 were male patients and 3 were female. And all the patients were diabetic, while 5 patients were known diabetics, and 5 of them were newly detected diabetics post-COVID-19 infection. So a repeat MRI was done after 4 weeks, but it was done only in 7 patients since 3 patients succumbed to the disease. The disease noted to be radiologically stable, and there was improvement in clinical symptoms and signs. So on the whole, it showed that the procedure, along with irrigation and the cover of systemic antifungals, had taken care of the disease locally. So improvement of clinical signs and symptoms. Within the first week of follow-up, all the 10 patients showed symptomatic relief, and chemosis was reduced in 9 patients, proptosis reduced in 5 patients, and lid edema reduced in 7 patients. So comprehensively, among the 10 patients, 4 were discharged after 6 weeks after completion of amphotericin B systemic dosage. 1 patient with who already had pre-existing membranoproliferative glomerulonephritis, she worsened, and it was considered for exenteration. 3 patients succumbed due to deterioration of cardiopulmonary status. 1 patient developed frontal abscess and underwent craniotomy for abscess drainage, while his ocular condition remained stable. 1 patient was lost for follow-up. So with this about data, we can tell the mortality rate accounts for 30% with globe survival rate in 85.7%. This pre-operatively, the patient had extensive chemosis and proptosis. Post-operative day 2 showed reduction in chemosis, congestion, and the catheter is placed. This is the post-operative week 1. There is significant reduction in chemosis and congestion compared to pre-operative state. Over the past several decades, newer modalities of treatment for rhinoorbital mucormycosis infections have dramatically improved the survival rates. So what we have to note is early diagnosis, while the disease is still confined to a particular compartment, gives better outcome for the disease. In MRI, enhancing orbital tissue is infected but still vitalized, whereas loss of enhancement represents a necrotic, unsalvageable fungal elements. It's always better to immediately debride the non-enhancing orbital tissue, followed by orbital irrigation of amphotericin or tram, so that the disease can be contained. Transconjunctival approach to the orbit for adequate debridement combined with amphotericin irrigation is a novel technique that can be considered for compartmental involvement of orbital mucormycosis. And debridement removes the necrotic tissue, while local amphotericin irrigation directly reaches the target tissue that effectively halts the disease progression, and it can be considered as an effective globe-sparing intervention without affecting the disease outcome. Thank you.
Local infiltration of amphotericin was given for how many days?
It was done alternative days 5 times, ma'am. So in the span of 10 days, 5 times the irrigation was done.
What is the percentage dosage of?
It's the same as tram, ma'am. 3.5 mg per ml.
Do you dilute it and give in the local infiltration form, or it in the same concentration as it is available?
We diluted it, ma'am. We gave it in the same concentration as we give transcutaneous amphotericin injection. We diluted it, the vial, and we gave it in the concentration of 3.5 mg per ml, ma'am.
How is the renal status after giving local infiltration?
As such, the patient was under the cover of systemic antifungal, so the renal parameters kept varying, but we don't have evidence of correlation between the local infiltration and renal status.
So Dr. Shivana sir. So Dr. Shivana sir, any questions from your side?
Ma'am, Dr. Shivana is not there.
Who else are the judges in this?
Dr. Vagish,
Is he there?
checking, ma'am.
Uh,
Doctor name is not visible.
Can you call him and invite?
Okay, ma'am, sure. Ma'am, he have some network issue. He's logging in 5 minutes.
Okay, may I know your name?
Shambhavi.
Okay. Okay, you can carry on with the next speaker.
Okay. Dr. Daneshwari, are you there? Dr. Yugendra? Dr. Yugendra, you can start now. Hello?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Dr. Daneshwari, right?
Yugandhara.
Hello?
Hello.
Ma'am, your name?
Yugandhara.
Okay, ma'am, you can start now.
1 minute.
Yugandhara's free paper number is 1194. How come it is 1224? Hello. Shambhavi.
Ma'am? Yes, ma'am, I'm also checking. Yeah.
Yeah, that is 1194.
Yes, ma'am.
Ma'am.
Let her
Ma'am, can I
confirm on
just get-
present.
Yes, ma'am.
Let her confirm on present.
Okay, ma'am.
Ma'am, can I start? Hello.
Yes, you can start now.
Good afternoon, everybody. I'll be presenting a paper on risk factors of rhino-orbital mucormycosis. Mucormycosis is a fungal infection caused by fungi which belong to the order Mucorales of the class Zygomycetes, which are ubiquitous in nature, especially in soil and decaying vegetation, and occur naturally in the environment, the body surface, and orifices. These fungi develop rapidly and release large number of spores into the air. Human beings are often exposed to these fungi through inhalation, and the spores inoculate the paranasal sinuses and the nasopharynx, with subsequent spread to the orbit and intracranial cavity in persons with decreased cellular and humoral defenses. The fungal hyphae of Mucoraceae family are angioinvasive, invade blood vessels, cause necrotizing vasculitis and thrombosis, resulting in extensive tissue infarcts and necrosis. It proliferates and spreads to the paranasal sinuses recently. The present COVID-19 pandemic has witnessed a resurgence of cases of rhino-orbital mucormycosis. Over the last 10 years, there has been a surge in predisposing factors for mucormycosis, and it has been seen that diabetes mellitus is the most common underlying disorder in an estimated 70% cases of mucor, and the renal disease being the second most common risk factor. Extensive use of steroids, monoclonal antibodies, broad-spectrum antibiotics may lead to development of exacerbation of a pre-existing fungal disease. The most common underlying illness of rhino-orbital cerebral mucormycosis are diabetes mellitus, hematological malignancies, hematopoietic stem cell transplantation, and solid organ transplantation. Early diagnosis with the institution of appropriate antimicrobial therapy saves both sight and life. The aim and objectives of the study was to assess the risk factors associated with rhino-orbital mucormycosis and to determine the clinical manifestation of rhino-orbital mucormycosis. It was a hospital-based cross-sectional study. It was a pilot study. Duration is 1 year. Sample size is 37. The inclusion criteria are patients of age 18 to 80 years were included, diagnosed with or having presentation of rhino-orbital mucormycosis, and patients with bacterial infections were excluded.
Total number of patients included were 37. Males were 31, that is 83.78%. So it is seen that males were more commonly predisposed to mucormycosis. Coming to the risk factor.
Ma'am, your voice is breaking.
He is not audible. Is it the problem with the relay?
Is it audible now?
Yes.
Now it is audible,
Yeah.
but suddenly it gets disappeared.
Okay, sir. Yeah.
Can you continue with your presentation?
Yes, sir. Yes, sir. Moving on, oxygen mask usage, especially during COVID-19 infection, was seen more, and those were like 62.16% of patients had a history of oxygen mask usage. Also, 45.94% of patients had underwent steroid treatment. Coming to visual acuity, the people with visual acuity 6/6 to 618 were around 21.6%. Less than 618 to 660 were 18.91%. Less than 660, but more than counting finger 3 meters were 13.5%. And from less than counting finger 3 meter to PL positive were 2 patients, that is 5.40%. 40%, and no perception to light, around 15 patients out of 37 patients were seen, that is accounting to 40.54%. In clinical features, lid edema was seen around 83.78%. Sinusitis was seen amongst almost 100% of patients. Congestion, chemosis was also seen. Congestion was seen around 35.13%. Chemosis around 48.64%.
Again, not audible.
Strongly associated with COVID-19 infection and diabetes mellitus, followed by use of oxygen mask and steroids treatment. Moreover, the patients presented with mainly lid edema, the ptosis, proptosis, patients presented with complete ophthalmoplegia and vision affected, based on which the treatment was being initiated at the earliest. A study by Ravani et al. Suggested that rhinoorbital mucormycosis is prevalent amongst COVID-19 patients and with HbA1c above 8, which suggests that in diabetic patients it was more prevalent. A study by N. Bairam et al. Suggested that severe COVID-19 is associated with rhinoorbital mucormycosis with higher mortality due to immune dysregulation and widespread use of steroids, which clearly says that it was more prevalent because of COVID-19 infection causing less immunity in patients, and with diabetic patients it was more common. Rhinoorbital mucormycosis has strong association with COVID-19 infection, especially who have used steroids, oxygen mask, and with type 2 diabetes mellitus. And early presentation with treatment can further prevent further ocular morbidity. Thank you.
Why there are more number of male patients who are involved who has ocular mucormycosis? What is the reason behind that? Can you be able to explain?
Yukandra, are you there?
Hello.
Hello.
Am I audible?
Yes, now.
More commonly seen in male patients. You
Hello,
have
sir.
many number of male patients who are affected with the orbital mucormycosis.
Yes, sir. Yes, sir.
Orbital mucormycosis. Why it is more common in males?
Sir, diabetics, sir, like diabetes mellitus prevalence was also seen
The
more.
incidence of diabetes mellitus can be like even females also may have
Yes,
diabetes mellitus, and the number of patients are something like the ratio between male and female is too much. Like,
yes, sir.
what is the reason? Any? Can you reason out why it is more common in males?
Sir, no, sir. Like I couldn't find the reason.
All female patients are diabetics.
Yes, sir. Most of them were diabetics, sir. Either they were known cases or newly diagnosed. Like.
Okay.
But only 23 patients of your 37, of total 37 patients, only 23 are diabetic. Is it, can you put that slide, please?
Ma'am. Okay, sir.
Yeah. So diabetes was 28 in number.
Yes, ma'am.
And the oxygen mask usage were only 23.
Yes, ma'am. But again, most of the patients, they had diabetes, not all.
So what is your conclusion? It is COVID-19 or diabetes mellitus is the risk factor for this?
Ma'am, both basically in COVID-19, since the surge of the infection was more during the, like after the second phase of COVID. So it was actually mainly, I feel it was the COVID-19 infection which had led to, which was the main cause. And also diabetes, ma'am, like because of the low immunity, immunocompromised status, it might have added up to it.
It can be also the lung compliance in males, because many of them may be smokers.
Yes, sir.
That may be one of the reasons that male patients may not have a good lung compliance.
Okay, yes, sir. Maybe.
That could be one of the reasons.
Yes, sir.
Were all the COVID-19 infected patients were not put on steroids?
Ma'am, all basically, ma'am, these patients had come.
In your presentation, steroid treatment was given only for the 17 patients. Usually COVID-19, once infection starts, they start with steroid treatment.
Let's find out the history about like of the steroid usage. Like that data has been included. So like around only 17 patients had given a proper history, or they had a previous discharge summary or a documentation in which any steroids were included in the treatment.
Can go to next paper, madam.
Okay, sir. Thank you, sir.
Dr. Rishabh, are you there? Dr. Kritika?
Ma'am, Rishabh, I'm there, ma'am.
Okay. Please present your presentation.
Yes, ma'am. Hello.
Yeah.
So my presentation for today is correlation of ophthalmological and radiological findings in rhino-orbital cerebral mucormycosis patients, a hospital-based study. Rhino-orbital cerebral mucormycosis is an acute, fulminant, and lethal opportunistic fungal infection. Rapid progress in immunologically or metabolically compromised individuals is observed in patients with COVID-19 infection. Early clinical presentation is typically with fever, headache, facial pain, nasal discharge, nasal obstruction, and crusting, progressing rapidly to cranial nerve palsies and features of CNS involvement. Early suspicion and rapid diagnosis and treatment are the most important factors that determine prognosis in the management of mucormycosis. Imaging forms the cornerstone of management in patients with ROCM, as they give corroborative evidence when the disease is clinically suspected. The aim of this study was to correlate the ocular and radiological findings that may be useful in predicting the association with clinically suspected ROCM. My objectives were to identify the ophthalmic and
Dr. Rishabh?
Yes, ma'am. I'm there, ma'am.
Okay.
The objectives of my study were to identify the ophthalmic and radiological features in predicting the diagnosis of rhino-orbital-cerebral mucormycosis, and to correlate the radiological features with the severity staging of rhino-orbital-cerebral mucormycosis. This retrospective cross-sectional hospital-based study was conducted on 45 biopsy-proven acute ROCM cases in the Department of Ophthalmology and Radiology at RLJ Hospital and Research Center, Kolar, which is attached to Sri Devraj Ars Medical College. After attaining approval from the Institutional Ethics Committee, the relevant clinical and imaging data from the medical records of patients with ROCM was reviewed and analyzed. So mean age of patients was 48.8 years. 36 were males out of 45 and 9 were females. 27 patients had unilateral presentation while 18 patients had bilateral presentation. 28 patients were COVID-19 positive and rest patients were post-COVID status. 33 patients 33 patients were known diabetics and rest and 7 patients were newly diabetic cases. 21 patients had history of systemic steroid use and 18 patients had oxygen masks use. So coming to the symptoms, set of the patients, and proptosis was present in 44 to 45% of patients. And other signs were cranial nerve palsies, total ophthalmoplegia, and CRAO. Sinuses involved were alone maxillary sinus was involved in 5 patients, frontal in 1 patient, maxillary plus ethmoid in 5 patients, ethmoid plus sphenoid in 4 patients, maxillary ethmoid plus sphenoid in 8 patients, and all sinuses were involved in 17 patients. Extent of regional involvement was involvement of nasal septum was seen in 2 patients. Bilateral nasal mucosa was seen in 13 patients. Bilateral PNS was seen in 14 patients, paranasal sinuses. Diffuse orbital involvement was seen in 7 patients. Superior orbital fissure was seen in 13 patients. Involvement was seen in 13 patients, and CRAO was seen in 8 patients. Bilateral orbital involvement was seen in 1 patient, and intracranial spread was seen in 4 patients. The most common risk factors for ROCM observed in our study are diabetes mellitus, post-COVID-19 status, and use of systemic steroids. Bilateral paranasal sinuses, that is stage 2B, and nasal involvement, that is stage 1D, was seen in 31.1% and 28.9% respectively, followed by 3rd, 4th, and 6th cranial nerve palsies, that is stage 3C, in 13%. And initiation of full dose liposomal amphotericin B is the definitive first step in the long and arduous management of ROCM. Thank you.
Rushabh, what correlations you could find?
Ma'am, correlation I could find was the most common risk factors I could find was diabetic mellitus and post COVID-19 status, and involvement was mostly involvement of paranasal sinuses, ma'am, and
Can you put that slide of
yes,
both the radiological and the clinical correlation?
Yes, ma'am.
This areas involved, you mean to say it is radiological?
Yes, ma'am. Yes, ma'am. This is radiological.
Then how can you say that CRAO is there in a radiological picture?
Ma'am, this is according to the staging of mucormycosis, ma'am. This many patients were present with this staging, this features, ma'am, and CRAO was present in 8 patients.
You mean to say that this CRAO was on ophthalmic examination, you could find that CRAO was present in 8 patients.
These are the stages. Probably he has
copied from the
book.
Yeah.
What are the radiological pictures you have?
No, ma'am. Now I don't have any pictures.
Then your topic itself is correlation between ophthalmologic and the radiologic findings in ROCM, isn't it?
Yes, ma'am.
So, Dr. Shivanna sir, you can ask the questions. There is no correlation at all here.
Yeah, that's right. We don't have any, what do you call, CT, MRI findings, and then.
Ma'am, we have all the pictures. Ma'am, we have all the pictures saved with us, ma'am. Like, if we give us some time, we can show, ma'am.
But your presentation, no? This is a presentation, free paper.
Yes, ma'am. But this, ma'am, we had a limitation of.
There is no correlation between your title and the topic. That's what your presentation.
Actually, we had a limitation of 10 slides, ma'am. So that's why we couldn't put.
It's okay.
There is nothing like a limitation. You can show the picture. So you need not talk about those pictures. You can show the pictures and skip the slides. So that gives a proof that you have sufficient document to say that correlation between your radiological findings and then mucormycosis.
Sir, we'll move on to the next speaker.
Manoj,
Hello, ma'am.
you can present now.
Okay. Good afternoon, everyone. Myself, Dr. Manoj. First of all, I would like to thank all the respected dignitaries for giving me opportunity to present this paper on this platform. My topic is on study on epithelization of orbital socket post-exentration in COVID-associated rhino-orbital cerebral mucormycosis. The authors of this study have no final disclosure on conflicts of interest with the presented material in this presentation. During the pandemic of COVID-19 SARS infection, India has experienced a surge of dreadful fungal infection, rhino-orbital cerebral mucormycosis. Mucor is a saprophyte of order Mucorales, and mucormycosis is an acute and often fatal opportunistic infection. The conventional management includes control of metabolic abnormality, administration of metabolic systemic amphotericin B, and surgery that involves simple sinus surgery clearance, radical debridement, and orbital exentration. Orbital exentration is surgical removal of orbital contents, including the eyeball. Exentration is performed as a life-saving measure for primary or secondary orbital malignancies, where conservative treatment has failed or is it not feasible. Exentration can be performed by either an eyelid sparing or eyelid sacrificing technique. Ideally, eyelid sparing technique with suturing of the eyelids is preferred. However, most of the patients in our setup developed wound gaping. Some surgeons advocate eyelid sacrificing technique with spontaneous granulation, where orbital cavity has to be lined by temporalis muscle, forehead flaps, or grafts, and this offers comparable cosmetic results. However, healing by granulation takes longer time and requires intensive post-operative care. So our aim of this study is to study the epithelization of... Hello?
Can you enlarge your slides?
Yes. Yes.
Full screen, yeah.
Yes, sir.
Okay,
It's a prospective comparative study conducted at a tertiary COVID-19 hospital between May 1st, 2021 and July 30th of 2021, where 35 patients were subjected to relevant medical history, ocular examination, patients with visual acuity, no perception of light, pupil dilated and fixed, severe proptosis, severe ptosis, with or without incomplete ophthalmoplegia, extensive involvement of skin over the lids, and bilateral orbital involvement are subjected for exentration. And patients were divided into two groups based on the surgical technique performed, namely eyelid sparing in group 1 and eyelid sacrificing as group 2. And these patients were followed up for epithelization of the orbital socket in eyelid sacrificing and wound healing in eyelid sparing exentration over a period of 4 weeks. So the results, out of 35 patients underwent exentration, 18 and 17 were included in eyelid sparing and eyelid sacrificing technique as group 1 and group 2. Of them, 13 were in group 1 and 13 and 14 were males, and 5 and 3 were females respectively, with male preponderance. Coming to the socket health, medial wall of the orbital socket healing at 2 weeks showed no granulation in 4 and 2, granulation in 14 and 15, whereas lateral wall showed no granulation in 13 and 10 cases, granulation in 5 and 7 cases respectively in group 1 and group 2. By 4 weeks, medial wall showed granulation in all 18 and 17 cases in group 1 and group 2, and lateral wall showed no granulation tissues in 2 and 1 cases in group 1 and group 2, and healthy granulation tissues in 16 and 16 cases. Suggestive of medial wall, like early granulation tissue formation compared to the lateral orbital wall. In eyelid sparing technique, wound gaping in eyelid sparing technique at 2 weeks and 4 weeks showed medially in 13 and 18 cases, laterally in 1 and 1, totally in 3 and 8 respectively. and wound gaping was seen more medially, followed by total gaping. It's a study conducted by Honavar S.G. Rao on enucleation and exenteration in surgical ophthalmological oncology concluded that these procedures can be life-saving and are used as a part of multimodal treatment in achieving complete local remission. Cosmetic disfigurement caused by these radical procedures must be rehabilitated by a well-matched prosthesis. And another study conducted by Putterman AM on orbital exenteration with spontaneous granulation, it was observed that spontaneous granulation technique provided better results when compared to split thickness graft technique. And another study done by Rahman et al. On orbital exenteration, a 13-year Manchester experience, it was found that healing of the orbital defect is purely dependent on the method used for reconstruction. They include temporalis muscle transposition, midline forehead flaps, dermal graft, split skin graft, globe sparing exenteration, eyelid sparing technique, and spontaneous granulation. Allowing granulation of defect may delay healing up to 2 to 3 months, and healing by secondary intention has advantage of being an easier and quicker procedure that allows recurrence to be detected early. However, in cases where exenteration is performed for palliation of the neoplasm, a split skin graft gave rehabilitation of the socket and minimize the hospital attendance, but it lengthens the duration of the. This is the one of the eyelid sparing technique performed after 2 to 3. The patient has been given for spectacle mounted prosthesis. So this comparative clinical study showed eyelid sacrificing technique with spontaneous has early and better granulation tissue formation in comparison to eyelid sparing with and delayed granulation. And these are my references.
You said something like globe sparing orbital exenteration. What does it mean? Globe sparing orbital exenteration.
Sparing where the eyelids, eyelashes, and eyelids and eyelashes are preserved, sir.
They are all adnexal tissues. What is the meaning of globe sparing?
Globe sparing where
that doesn't mean anything, no? Globe sparing. You are not sparing the globe. You are removing.
Yes, sir. There's no. We are not sparing the globe, sir. Where hold the eyeball and the surroundings also, including the muscle.
Leaving behind the eyelids and eyelashes. That is one of the techniques.
Yes, sir.
But globe sparing orbital exenteration, I don't know why they have mentioned that globe sparing orbital exenteration.
Yes, sir.
No, you have mentioned here.
Yeah, sir. In the
what is
done by Rahman et al. There was split skin graft, globe sparing exenteration also, eyelid sparing technique, and spontaneous granulation.
Eyelid sparing is okay, but what is globe sparing?
Yes.
I don't know. Is it better to do grafting, skin grafting on the orbital wall? Or you allow it to heal by spontaneous granulation? Which is better?
Yes, sir.
Which is better?
Sir, lid sparing. Lid sparing is better, sir.
Okay. Okay.
Processes.
So that we will have a better cosmetic results.
Yes, sir. As it's in this picture, we can see, sir, this is one of the ideal lid sparing techniques, sir, where the healing was without any wound gaping, and there was just one fistula at the medial side, sir.
You said the granulation tissue formation is healthy in the medial.
Yes, ma'am.
Medial wall exam approach.
In our setup, ma'am, also in our setup, all the patients which we had observed at 2 weeks and 4 weeks, there was a better wound healing medial wall.
Why do you say it is? Why do you say
lateral wall?
Why do you say?
Ma'am, based on the involvement of sinuses, ma'am. Based on the involvement of the sinuses, like the medial ethmoid sinus and maxillary sinus. and those patients
What are the
who
marks of the
had sinus ethmoidectomy and maxillectomy showed delayed gaping at the medial sides.
What do you need for a better granulation tissue to be formed? Is that a vascularization or the sinuses?
Yes, ma'am. It's the vascular. It's
So,
the vascular.
the medial wall approach, the vascularity will be high.
Oh, yes, ma'am.
Where was this study
in our
done?
study, it was.
Where was this study done?
Ma'am, it was done at Minto Eye.
Okay.
In Bangalore Medical College.
Okay.
Yes.
So,
Yeah, can go to the next person.
Okay. Thank you, sir.
Okay,
Thank you,
right.
ma'am.
Okay, right.
Shambhavi, can you call up the next speaker?
Whoever is ready, the rest of the list can start up their presentation.
Good afternoon, sir.
Krutika is going to present now.
Yeah, sir. Yes, sir.
Okay, go ahead.
Good afternoon, everyone. Today, the paper I'm talking about is correlation of severity of mucormycosis with the levels of the inflammatory markers in COVID-19 patients. Introduction: coronavirus is caused 2019 is caused by severe acute respiratory SARS-CoV-2, which has been associated with wide range of opportunistic bacterial and fungal infections. Recently, several cases of mucormycosis in patients with COVID-19 have been increasingly reported worldwide, particularly in India. Mucormycosis is an angio-invasive disease caused by mold fungi of the genus Rhizopus of order Mucorales, and classification is by zygomycetes. Rhizopus oryza is the most common type and responsible for nearly 60% of mucormycosis cases in humans, and also accounts for 90% of the rhino-orbital cerebral form. Mucormycosis typically affects the immunocompromised individuals with an impaired neutrophilic response. Various factors contributing to this sudden surge have been put forward, like deranged blood sugars, use of systemic steroids and immunomodulators, oxygen therapy during hospitalization, and use of damp, unclean masks. This prompted us to study the role of inflammatory markers during COVID-19 infection in facilitating this ramped infection. Lactate dehydrogenase, C-reactive protein, procalcitonin, and more recently, my study included 45 COVID-19 positive patients. It is a retrospective cross-sectional observational study. Clinical and laboratory data were compiled from patients with mucormycosis admitted in COVID-19 wards in a tertiary care center. Statistical analysis were done by clinically according to the severity of ROCM, serum ferritin, lactate dehydrogenase, D-dimer, total count such as neutrophils and lymphocytes were considered as primary outcome variables. Severity of ROCM, stage 2, stage 3, and stage 4 mucormycosis were considered as primary explanatory variables. The results in my study showed that the sex distribution, it was more common in male, that is of 79.2%, and in females it was 14.6%. According to the stages, in stage 2, there were 57.8% of the patients, and the stage 3, there were 33.3%, and in stage 4, there were 8.9%. The parameters such as serum ferritin, in which patients with normal serum ferritin were 44.4%, and patients with high were 55.6%. Serum lactate dehydrogenase, the patients 33.3% had normal values, and 66.67% had high values of serum lactate. ROCM is progressing. The parameter values were also increasing, and the p-values were significant for serum ferritin, serum lactate dehydrogenase, D-dimer, and total count. Discussion: mucormycosis is an emerging problem in individuals with COVID-19 as well as the healed cases, and denotes a poor prognosis. Globally, the prevalence has been as low as 0.05 to 1.7 per million in the past, but after COVID-19 in India alone, the prevalence has gone up to 1.4 per thousand. In our study, ROCM incidence was higher among males than females. Moreover, this finding was comparable to the previously published data during the pre-COVID-19 era.
Inflammatory processes are triggered usually by rapid viral replication of SARS-CoV, and cellular destruction can recruit the macrophages and monocytes and induces the release of cytokines and chemokines. So these cytokines and chemokines will then attract the immune cells and they will activate the immune response, leading to the cytokine storm and the aggravations. But et al. Has proposed three possible theories for ROCM. The first one is lymphopenia, which is due to the dramatic reduction in the availability of T cells and which serves as an opening entry gate for opportunistic fungal infection. The second theory was the increased pro-inflammatory markers, and the third was hyperferritinemia, which was caused by excess interleukin-6 release and macrophage activation. Inflammatory markers such as procalcitonin, serum ferritin, erythrocyte sedimentation parameters might help to reduce the severity of ROCM by treating it at an earlier level. Conclusion: the measurement and monitoring the trends of inflammatory markers will help to predict and evaluate the severity and prognosis of ROCM in COVID-19 patients. These were the references. Thank you.
As you said,
Yes, sir.
the level of serum ferritin is one of the reasons for the opportunistic fungus mucormycosis, rhizopus.
Yes, sir.
Any other reasons to correlate, like other inflammatory markers?
Other inflammatory markers.
Actually, in all these inflammatory markers are increased in most of the patients. Why only few of them are being affected? Is it because of the usage of steroids to suppress the cytokine storm has led to the development of mucormycosis in these patients?
Sorry, sir, I couldn't hear you.
You couldn't hear me?
Hello, am I audible?
Is it because of the usage of steroids to bring down the inflammatory markers? And
That be one of the reasons, sir.
yeah, in all your papers, only male patients are more predominantly involved than female patients. Nobody could explain to me what is the reason behind the higher incidence of mucormycosis in male patients. Go on to next paper.
Okay,
Hello,
doctor.
sir.
Dr. Surabhi?
Sir, ma'am, can I present now, ma'am?
Yes, ma'am.
Hello, hello, teachers. Sir, good afternoon. I'm presenting a case of endogenous panoptomitis with orbital cellulitis simulating mucormycosis.
1 second, Surabhi. 1 second.
Ma'am.
Your this one is not there in the list.
Ma'am, yeah, ma'am, but it came Gmail. It came, ma'am. I
want the confirmation from Shambhavi.
Okay, ma'am.
Sir, Dr. Shivanna is there in your list? Surabhi's names. Shambhavi, can you confirm and say? Surabhi's name is not there in the list of 3 to 5 presentation. Is that audible?
Hello, doctor.
Hello, ma'am.
Surabhi's name is not.
Yeah, Surabhi's name is not on the list. We won't be able to give marks on the mark sheet unless the name is there.
Okay.
We'll have to add up her name.
Okay.
Yeah, it's not there in the list. What shall we do?
1 minute, doctor. I'll check once again.
Ma'am, I came at it as early day 2.
Yes, Surabhi, your name is not there.
It came it is as early day 2, 11, 12, 21.
This is Hall E. Hello, Surabhi.
Yes, ma'am.
This is hall E.
Okay. Mine it is came it is as a early and only.
Can we move to next presentation?
Okay.
Dr. Rashmi, are you there?
Yes, ma'am.
You can present now.
Yes, ma'am. Is my screen visible, ma'am?
Okay.
Yes, visible.
Go ahead, madam.
Good evening, everyone. Myself, Dr. Rashmi is from KIMS Hospital, Bangalore. I'm going to present eyelid retention cyst. It is a thin wall lesion with clear or occasional turbid fluid. There is a patient, 13 years old female, who presented with a swelling in the
Share
left
your
lower
slide.
eyelid.
Share your slide.
I've shared. Is it visible, ma'am?
You're not going to next slide. You're not moving on to next slide. And you magnify your slides.
So in mine it is it visible? No, sir. No, sir.
You are stuck onto one slide. Yeah. Now go ahead.
Yes, sir.
Zoom your presentation.
Is it visible, ma'am?
It's visible, but try to zoom it, no?
Now, ma'am, I've shared my screen. Like slideshow is going on.
Yeah, slide is visible.
There is
Try
a
to zoom it.
In mine, the slideshow is coming and it is clear. The slides are moving, ma'am, but I think it's not visible. Is it visible, ma'am, now?
For me, it is visible, but Dr. Shivana is facing problem.
I've zoomed it
Go
also.
ahead. Go ahead, it's okay.
Okay.
Yes,
You're not able to zoom, it is okay.
yes. So this is a case of 13-year-old female who came with a complaint of swelling in the left lower eyelid since 2 years. Her attender gives history of installation of anti-allergic eye drops when the patient was at 2 years for red eyes and watering of eye. There was no history of trauma, no history of previous surgery, no history of pain. The patient had developed a small swelling in the lower eyelid, which was noticed at the age of 2 years, and it was neglected. Since 2 years, the swelling of the eyelid has progressed to the current size. It is seen in this image. There was no history of pain, no history of discharge, no history of restriction of ocular movements, no history of trauma, or no history of surgery in the previous eye surgeries. Previous eye surgeries. On examination, there was a fluid-filled mass in the lower fornix of the eye. But there was no communication with the globe and no increase in size on bending forward or on Valsalva maneuver. On slit lamp examination, a translucent bluish firm cyst was seen, which was measuring 15 into 5 mm in size. CT orbits was done, which showed a non-enhancing cystic to hypodense lesion in the left lower orbit, which is seen here.
Rashmi,
No
again,
evidence.
your slides are not
Why
being.
you are not showing the slides? The only first case report slide is seen.
Now, ma'am?
Now we can see CT scan report. So we haven't seen the other slide, second one.
I'll go to previous one.
Okay, okay, right. Okay, go to next slide.
Yes, sir. On examination, this fluid-filled mass was seen in the lower fornix of the.
That you have already finished. Go to the next slide. CT
Yes.
scan or something like that you have.
Yes, sir. The CT scan showed a non-enhancing cystic to hypodense lesion in the lower
left eyelid with no evidence of adjacent infiltration or intracorneal extension. MRI orbits showed a cystic lesion in the anterior 1/3 of the extracorneal compartment of left orbit, no infiltration into the muscle, or it is separated from the globe. You can see here there is no infiltration into the muscle, or and it is separated from the globe. Anterior orbitotomy using a subciliary incision approach was made, and the mass was excised. Hydrodissection from the conjunctival side was done using lignocaine to separate the cyst from the anterior side of the conjunctiva.
Project your slide and then present. Whatever you are presenting, no, project that slide.
Yes. Anterior orbitotomy was done using a subciliary incision, and the mass was excised. The hydrodissection from the conjunctival side was done using the lignocaine to separate the cyst from the anterior side of the conjunctiva. And the mass was sent for histopathology. Histopathology report showed a thin fibrocollagenous cyst wall lined by a double layer of cuboidal epithelium admixed with a few mucinous cells. Diagnosis is made as conjunctival retention cyst. There were many studies were conducted on conjunctival retention cyst. In 2015 and 2018, it was noted that the similar case report was studied, and surgical management was done, and it was found to be conjunctival retention cyst, and the patients also had a similar history of use of anti-allergic medications in the past. This is a picture of my patient before the surgery and post of 6 weeks.
Project that slide.
This is the picture of my patient before the surgery at the time of presentation and post of 6 weeks.
Has the swelling extended into the orbit?
No, sir.
Huh?
It did not extend to the orbit, sir.
Okay, so it is outside the orbit.
Yes, sir.
Front to the orbital septum.
Yes, sir.
Isn't it? So
Yes,
it
sir.
is in the conjunctiva, inferior fornix.
Yes, sir.
There is a retention cyst.
Yes, sir.
Conjunctival retention cyst in the inferior fornix.
Yes, sir.
Okay.
The conjunctival retention cyst mostly causes a foreign body sensation, irritation, and a cosmetic blemish. The topical eye medications with preservatives cause toxic effects to the eye. The conservative treatments like puncture of the cyst can lead to recurrence of the conjunctival cyst. So surgical excision with the cyst wall is the effective cure. Thank you.
Rashmi, what is your title?
Ma'am, eyelid retention cyst, ma'am, because the patient, when she presented, it was.
Why did you say it as eyelid cyst? It is conjunctival. It's a conjunctival retention cyst you have mentioned, no?
Yes, ma'am. But
why did the title has been changed as eyelid cyst?
Yeah.
Eyelid is nowhere involved.
It's not eyelid cyst, madam. If it is a cyst in the eyelid, it could be what do you call chalazan.
Sir, yes, sir.
You said the eyelid cyst is not the word to be used. As madam said, it is a conjunctival cyst. Isn't it?
Yes, sir. But
sir, you are wrong in putting things.
When the patient presented, it was diagnosed, like we thought it was eyelid cyst, sir, but on a histopathological examination, we found out it was
no, not like that. On examination, it is visible in the conjunctiva, not on the lid. So don't say that it is an eyelid tumor, eyelid cyst.
Yes,
it is more of a conjunctival cyst rather than eyelid.
Yes, sir.
What is the difference between retention cyst and implantation cyst?
Ma'am, retention cyst due to goblet cell loss, there is a block in the duct, ma'am. Whereas inclusion cyst, it is the epithelial of the conjunctiva is merged with the connective tissue of the conjunctiva.
What is the cause for it? Implantation system.
Due to trauma or previous surgeries.
Mainly foreign body. Okay. So next speaker.
Yeah.
Okay.
Dr. Deepak?
Hello, ma'am. Hello.
Yes.
I'll share the screen, ma'am.
Okay, sure.
My screen share is visible, ma'am. Hello. Hello.
You can carry on. It is visible.
Good evening, everyone. My free paper is 957, and my title is Transcutaneous Retrobulbar Amphotericin B used as an adjuvant in ocular mucormycosis. Objectives of the study is to know the effectiveness of, introduction. Rhino-orbital cerebral mucormycosis is a life-threatening angioinvasive disease seen almost exclusively in immunocompromised hosts. COVID-19 pandemic has found to increase in the disease of mucormycosis being an independent risk factor apart from its treatment from steroids leading to immunocompromised state. Other risk factors include diabetes and immunosuppression therapy. Due to the increase in the number of cases of mucormycosis, active treatment becomes essential. From many years, treatment consisting of systemic antifungals along with debridement, excenteration, and functional endoscopic sinus surgery and reversal of immune status. Since it's an angioinvasive disease leading to vascular thrombosis, poor penetration of systemic antifungals is noted. Transcutaneous retrobulbar amphotericin B is a minimally invasive and safe technique. It is used along with systemic antifungals and other procedures like functional endoscopic sinus surgery, debridement, and excenteration. Objectives of our study is to know the effectiveness of transcutaneous retrobulbar amphotericin B, which is used as an adjuvant in rhino-orbital mucormycosis in COVID-19 pandemic. Coming to the methods and materials and methods, the study was a retrospective interventional study and the sample size was 27. And the source of data was 43 patients admitted in post-COVID mucormycosis ward. It's a retrospective study was conducted on 27 patients of mucormycosis with rhino-orbital involvement who were receiving systemic amphotericin B and had undergone FES surgery. After satisfying inclusion and exclusion criteria, they were given transcutaneous retrobulbar amphotericin B for 7 days consecutively. Visual acuity, proptosis, and swelling was observed first day and after 2 weeks. Coming to the procedure of TRAMB, a test dose of 0.5 ml of amphotericin B was first injected. Then liposomal amphotericin B 50 mg vial was taken and was diluted with 14 ml of sterile water, which will make a concentration of 3.5 mg per ml, and it is wrapped in a dark paper. In an aseptic precaution, site to be given tram is instilled with a drop of topical anesthesia and painted. 1 ml of 2% lignocaine is injected into the subcutaneous space, followed by 1 ml of liposomal amphotericin B, which containing 3.5 ml is injected in 2 ml is taken in a 2 ml syringe with 26 gauge 1-inch needle and passed inferiorly at the junction of medial 2/3 and lateral 1/3 directly and directed inferior-medially without any resistance. Slowly, 1 ml of the injection is pushed into the retrobulbar space and proptosis and tense globe is noted. These were the images of the patients who were given tram. Coming to the results, there was no change in the visual acuity in our study. 27% of the severe ptosis improved to mild ptosis, 15.4% of the moderate ptosis improved to mild and no ptosis, and 46% of patients with swelling has been recovered. Coming to discussion, there was no change in the visual acuity. Unlike other study, it can be initiated effectively in patients in whom aggressive orbital debridement is not favored or the burden of a disease is not substantial. There can be transient inflammation from amphotericin B deoxycholate as per few studies. And TRAM B with local debridement can be an alternative to excenteration. Unlike our study, most of the patients underwent FES debridement along with systemic amphotericin B. Conclusion, TRAM can be used effectively for treatment of rhino-orbital mucormycosis and also where other therapies cannot be used. These are my references. Thank you, ma'am. Thank you, sir.
Deepak, why do you call it as a retrospective study?
Ma'am, earlier it was taken retrospectively, ma'am. We have not before, after the study was done, we were taken, we were planned of making it.
Then for your
earlier.
study, it becomes a prospective, isn't it?
Yes, ma'am.
Last but one slide, can you project? Not the bibliography. Before this. How many of your patients had transient inflammation?
Ma'am, inflammation was not noted, ma'am. Only one patient has retro RBH, ma'am. And hemorrhage was there only in one patient, ma'am. No inflammation and all was not there.
But the composition was same, isn't it? Amphotericin B deoxycholate.
Yes, ma'am.
Sir, Dr. Shivana, sir. Why didn't you see that there is no improvement in the visual acuity in all of your cases?
Most of the patients had posterior segment involvement, ma'am, like CR, combined CRAO and VIVO, or only CRAO with sparing of macula and retinitis, ma'am.
At the presentation, what was the visual acuity of these patients which you have considered?
A few patients had few patients presented with PL negative only, ma'am, but few had good vision, ma'am, that remained the same, ma'am.
In your references, was there any improvement in the visual acuity with retrobulbar?
Yes, ma'am. In one paper they have told there was an improvement of visual acuity, ma'am.
Were all the patients survived after your study?
We didn't follow up, ma'am.
Okay. Shivana, sir, any questions from your side?
Go ahead with next paper, madam.
Okay, doctor. Dr. Konduru Rishita is there?
Yes, ma'am. Once I'll share. Am I audible, ma'am?
Yes. Yes, ma'am.
Okay. Okay. A very good evening to everyone. I'm Dr. Konduru Rishita, second year ophthalmology PG from KIMS, Bangalore. The topic I'll be presenting is sebaceous gland carcinoma of the lower eyelid. Sebaceous gland carcinoma is rare, slow growing, and usually it is considered as an aggressive eyelid neoplasm. It is usually termed as masculine syndrome as it mimics many benign pathologies like chalazion, blepharoconjunctivitis, keratoconjunctivitis. Wide local excision remains the mainstay of treatment for sebaceous gland carcinoma, and reconstruction of the eyelid is the most challenging part of the management. So here is a case report of 45-year-old male who presented with a mass in the right lower eyelid for the past 1 year. He gives a history of incision and biopsy done on August 2020. So on examination, there was a non-tender mass present in the middle 1/3 of the lower eyelid of size around 3 × 1.3 centimeter with irregular nodules present within the mass. It was a well-defined mass which was firm in consistency, and there were dilated vessels, feeder vessels present, and the mass was mobile and the skin over the mass was pinchable. So MRI orbits was done for the patient where it showed a well-defined partially exophytic lesion in the right lower eyelid. There was no involvement of extraocular muscles, and there were no extension to bony margins. This mass involved the inferior tarsal plate. So our plan was wide excision and biopsy of the mass with reconstruction of the lid under general anesthesia. So first skin marking was done, which was followed by a conjunctival marking, and the mass was excised. So this is the photo of the eyelid defect post-excision. So now to reconstruct the posterior lamella, the lateral part of posterior lamella was reconstructed using periosteal flap, and the medial part of the posterior lamella was reconstructed using a hard palate mucosal graft. So this is a picture of the posterior lamella reconstruction. And for the anterior lamella, we used a monopedicle upper eyelid skin flap from the ipsilateral eyelid. And this is the picture of the anterior lamella reconstruction. So finally, this is the picture of the excised lid mass with margins, which was sent for histopath. So on histopathological examination, there were tumor cells with mitotic activity, and there were also areas of necrosis. So the report revealed poorly differentiated sebaceous carcinoma with free margins. So the post-op progress, there was a graft failure was observed in the second post-operative week. So the patient was taken for a revision surgery where a Hughes procedure was done. Hughes procedure is a lid sharing procedure. So here, the posterior lamella is reconstructed again using a tarso-conjunctival flap from the ipsilateral eyelid, and we have taken the anterior lamella was reconstructed using the contralateral skin muscle graft from the contralateral eyelid. And then a flap division was done after 11 weeks. So there are many articles published on sebaceous gland carcinoma. So one of the article published in IJO mentioned that it is the most common eyelid malignancy in India. And another study done at LV Prasad on clinical pathological features of sebaceous gland carcinoma shows that upper eyelid is the most common site of sebaceous gland carcinoma, and females were more affected, and the mean age group was around 57 years. So this is the conclusion. My patient who was photograph of my patient at presentation, and this is the post-op week 25th. I apologize for the poor quality of the post-op picture, as the picture was taken by the patient himself, and his latest follow-up is still on due. So the conclusion is sebaceous gland carcinoma is still a challenge to ophthalmologists, as it mimics many benign conditions. And the goal of reconstruction is to ensure that a movable eyelid is present and good corneal protection, and we should reproduce the same texture of the eyelid. Here, the purpose of presenting this case is just to highlight the importance of early diagnosis and need for thorough instruction. Thank you. Hello, ma'am.
What are the other differential diagnosis for your?
Like this mimics benign conditions, so it may mimic like chalazion. Chalazion is one of the differential diagnosis, and blepharoconjunctivitis, and patient might present with unilateral blepharitis also. So that time we can think of sebaceous cell carcinoma, and if you go by histopathological wise, it can be squamous cell carcinoma or basal cell carcinoma.
What are the secondary sites of this one tumor spread?
Metastasis, it can go into lung, liver, and the lymph node metastasis also can occur. That is the most common. So if there is
local, you have not mentioned about the lymph node. Which lymph node you have to check?
Lymph node for this patient, there was no lymph node involvement.
It is rare.
You can do a parotid lymph node is most commonly involved. So in patients with local recurrence, we can do a sentinel lymph node biopsy.
What is sentinel lymph node?
The first lymph node where the tumor starts, the first lymph node involvement. Sorry.
So what are the investigations you ask for in your follow-up, in the follow-up of your case?
Follow of my case, we can like in any tumor markers for sebaceous gland carcinoma or anywhere recurrence or
What investigations you will ask for?
tumor marker test, blood protein test also can be done.
Other than
so a bone marrow biopsy also can be done. Just
radiologically
or PET scan can be done.
So the non-invasive procedures are more ideal.
Okay.
So Dr. Shivana sir, any questions from your side?
No, madam.
Thank you.
Next speaker.
Thank you, ma'am. Thank you, sir.
1168.
Good afternoon, everyone.
Your name?
Daneshwari Devi.
Okay.
Ma'am, can I start the presentation?
Yes, you can start.
Good afternoon, everyone. Today I'm presenting posterior segment findings, examination findings in post-COVID mucormycosis patient. Introduction: rhino-orbital cerebral mucormycosis is a life-threatening angio-invasive disease seen almost exclusively in immunocompromised hosts. COVID-19 pandemic has found to increase in disease of mucormycosis being independent risk factor apart from its treatment from glucocorticosteroid leading to immunocompromised state. Other risk factors include diabetes and immunosuppression therapy. Due to the increase in number of cases of mucormycosis, active treatment becomes essential. Posterior segment findings plays an important role in the vision outcome in patients with post-COVID mucormycosis. Objectives is to find out the posterior segment findings in post-COVID mucormycosis patients. Methods: a prospective study of 29 post-COVID mucormycosis patients admitted in mucormycosis ward were dilated and fundus examination was performed with indirect ophthalmoscope and slit lamp with 90D at initial visit and at 2 months after treatment. 20D fundus imaging was captured for follow-up. All patients were classified into 2 groups based on age, less than 50 years of age and greater than 50 years of age. Results include mean age of post-COVID mucormycosis patients was 49.72, 12 were female patients and 17 were male patients. 31% had visual acuity of perception of light negative and 20.7% had 6/6 visual acuity. 27.6% had optic atrophy and 51.7% had normal fundus. Other findings includes combined CRVO with macula sparing and post-viral retinitis. Here's a few images captured with 20D lens with smartphone device. This is a picture of post-viral retinitis with RP changes. And this is a picture showing combined CRVO. This is a picture showing RP changes, other 2 pictures showing RP changes in post-viral mucormycosis patient. And this is the picture showing retinitis involving papillomacular bundle extending up to the macula. And this is a picture showing CRVO. Conclusion: post-COVID mucormycosis is a rapidly progressive and often fatal complication with a propensity to cause vascular occlusion, thrombosis, and infarction in patients with diabetes or those who are immunocompromised. The organism can spread to the orbit, extraocular muscles, and ophthalmic artery and optic nerve. Treatment of post-COVID mucormycosis requires a multidisciplinary approach that relies on prompt institution of antifungal therapy, control of the underlying predisposing condition, and when possible, surgical debridement. Despite early treatment, progression of the disease often occurs and mortality is high. This is my reference. Thank you.
What was the commonest presentation of your cases in the posterior segment finding? commonest presentation?
Manishwari, what is the most common presentation?
Optic atrophy.
Posterior segment in mucormycosis.
Sorry.
Yeah. Commonest presentation.
51.7% normal fundus. 21.76 had optic atrophy, ma'am. Hello.
So this post-viral retinitis is not a common finding as far as
Yes, yeah.
mucormycosis is concerned. So this is
Yes, sir.
CRO is the CRAO or CRVO is the most common
Yes.
presentation with the COVID, post-COVID mucormycosis.
Yes, sir.
More common is vascular involvement rather than neural involvement.
Yes, ma'am.
Okay, next speaker, please.
Dr. Priyadarshini, are you there?
Yes, ma'am.
Okay, you can present now.
Okay. Sharing of screen. Hello, ma'am.
Yes.
Good afternoon, everybody. Am I audible, ma'am?
Yes.
Oh. My free paper presentation will be on the bilateral orbital mucormycosis in patients at a tertiary hospital. Coming to the introduction part. So mucormycosis is a group of invasive infection caused by filamentous mucorale family. And in mucorale, we have two groups, that is rhizopus and mucor. Among mucorales, the rhizopus species is the most common infection seen. And mucorales is the third most common cause of fungal infection after Candida and Aspergillus species. Mucorales occur through the pathogenesis of how the mucormycosis occurs is by either spore inhalation or through angioinvasion. So in spore inhalation, these invade the paranasal sinuses mucus and erode through the bony walls of the orbit and skull base and then into the brain, causing the orbital and the cerebral infection respectively. And the fungal growth is enhanced by the high glucose, high iron and acidic environments. So the other pathogenesis is the angioinvasion, which allows the organism to disseminate to the other organs. And there is a ischemic necrosis, which impedes the delivery of the antifungal agents to the target tissue. So aim of my study, this is to assess the clinical profile, risk factors, pathogenesis, and the management of the bilateral orbital case, mucormycosis cases. So it was a retrospective observational hospital-based study, including all post-COVID-19 mucormycosis patients presenting in a tertiary care hospital, which was dedicated for mucormycosis management. And my study period was from April 2021 to August 2021. And it was hospital-based study. My sample was about 15 cases. So initially, we have done a clinical evaluation and vision of all the patients with a pupillary reaction, and we have done slit lamp examination along with the fundus and investigations for all these patients like MRI brain, paranasal sinuses, orbit, and diagnostic nasal endoscopy, biopsy, and CT orbit was done, including the systemic blood investigations to rule out other systemic diseases like diabetics and hypertensive and renal diseases. The results of my study, 100 patients presented to the manifestations of mucormycosis, among which they were found to have bilateral ocular involvement was found in 15 patients. Most affected age group was about 40 to 60 years of age, and diabetic patients were about 13%, and COVID-19 status was positive in 10 patients. And there was intracranial extension in bilateral ROCM cases as evidenced by MRI brain
PNS and orbit, which was seen in 14 patients. So this is the same thing in which, yes, sir. So this is a 15% bilateral mucororbital cases seen, and the rest of the cases were unilateral manifestations. The same thing, 13% age in age group of 40 to 60 years, and 10% were COVID positive, and 13% were diabetics. So the management of these cases, the mainstay of management was IV liposomal amphotericin B injection, which was given for 14 days in a dose of 5 to 10 milligram per kg, and control of systemic diseases and antibiotic coverage was given. Along with that, retrobulbar injection of amphotericin B transcutaneously was given, and IV posaconazole injection as a salvage therapy, and surgically there was excenteration and debridement to reduce the disease burden was done. So coming to the discussion part, with the onset of COVID-19 pandemic, there was a sudden surge of cases of mucormycosis was seen. So all the ocular structures may be involved in patients with COVID-19 infection. Orbital mucormycosis seems to be more aggressive and far fatal complication. And there were very few cases of bilateral blindness in COVID-19 have been reported. They were related either to the orbital location of mucormycosis or to the neurological complications, so including the bilateral optic neuritis and occipital ischemic strokes were seen. So presentation in our patient suggested cavernous sinus thrombosis, which was leading to carotid thrombosis, together leading to central retinal artery occlusion. And these from the ophthalmic and the other orbital arteries, fungal infection advanced into the opposite cavernous sinus. So this resulted in bilateral vision loss and complete ophthalmoplegia. And on successful treatment of ROCM, highly depends on the early diagnosis, control of underlying predisposing factors, and aggressive debridement. So there was a high index of suspicion of mucormycosis development in diabetic patients with corticosteroid treatment with COVID-19 illness. Conclusion, effective treatment of ROCM includes, first is the early diagnosis, and then reversal of the underlying risk factors, and then surgical debridement, and then most common is the prompt antifungal therapy. So there was a poor survival associated with delayed diagnosis and treatment, and along with the intracranial, that is cerebral involvement, and bilateral sinus involvement, and renal diseases cases. So this indicates that there is an aggressive nature of mucormycosis leading to high mortality rate. Hence, we need to treat them early. So these were my references, ma'am.
What was the mortality in cases of bilateral orbital mucormycosis involvement? Rate of mortality?
There was only, yes, ma'am, the mortality rate was high because on follow-up we have seen only one patient survival. Rest all in my study, they had death had occurred. So only one patient is remaining who is coming up for the follow-up, ma'am.
IV posaconazole was given for how many days? The treatment was completed for all your cases of 17 cases?
No, ma'am. Actually, during the process of treatment, only due to the extension, they had all gone. They did not receive the complete treatment, ma'am. But the other survival patient, he received actually tablet posaconazole also, and he received complete amphotericin and IV injections also, ma'am. He survived.
So the availability of lyophilized amphotericin B was not available in hand, especially in bilateral cases. Were you able to give all the amphotericin, whatever the dose mentioned, for 14 days? Were you able to give amphotericin B? Yes. Was it available in your hospital?
No, sir. Due to that only, they have started them on IV posaconazole as a salvage therapy because there was no availability of amphotericin.
Paper.
Dr. Dilshar, are you there?
Dilrush, can you increase your volume? It is not audible.
Can you hear me now, ma'am?
No.
Hello? Can you hear me now?
Yeah.
Hello?
Is that Dilrush speaking?
Yeah, yes, ma'am.
Okay.
Can you hear me?
Yeah.
So it's a minimally invasive procedure, globe sparing, alternative procedure.
There is echo from your.
Minimally invasive globe sparing alternative procedure. Am I
It's audible, but there is an echo.
what about now, ma'am?
Yeah. You can carry on now.
So it's a globe sparing alternative procedure with favorable outcome, avoids disfiguring and debulking procedures like exenteration. So what we did over here is we used a 50 milligram of liposomal amphotericin B. We diluted it with 10 ml of sterile water to get a concentration of 5 mg per ml. And under aseptic precautions, we gave 0.7 ml, which is 3.5 milligram retrobulbar injection of amphotericin B with a 23 gauge needle using transcutaneous approach. Most commonly for most of our patients, we gave it near the medial orbital site as the infection usually comes from that side. So for the purpose over here, we use an alternative day 7-day dose regimen of TRAM for ROCM treatment in post-COVID-19 patients. So inclusion criteria, those patients who were diagnosed as ROCM cases with a history of COVID-19 positivity. So in exclusion criteria, since we wanted to see the visual outcome, we excluded any patient with PL negative, those who are contraindicated for TRAM, that is any kidney RFT dysfunction, and also patients who had eyes pre-existing ocular disease and patients with CNS extension. So if there was any patient with CRA or etc., we did not take them into our study as it will affect the outcome. So method, it's a prospective community interventional study. It was done from May to August 2021. All patients received IV liposomal amphotericin B daily for 14 days. TRAM 3.5 milligram of amphotericin B injected retrobulbar with 23 gauge needle every 48 hours with or without surgical debridement of sinuses. Most patients ended up requiring surgical debridement of sinuses. And documentation of visual acuity on extraocular movement was done. Re-injection after 7 doses of TRAM and after 1 month of completion of TRAM. So in the results, 70 post-COVID ROCM patients were followed up for a minimum of 1 month. 2 patients had increased pain and swelling following first injection, which subsided in the next 2 to 3 days. And after that, we had continued giving the TRAM injections to the same patients as well. Lid edema, chemosis, and proptosis reduced 1 week following TRAM in 84% of the patients. But there was no visual acuity improvement noticed in the patients even after 1 week following the 7 doses. But after 1 month, significant improvement in visual acuity and extraocular movements was seen in more than 80% of the patients after 1 month. And many patients got like their previous vision after 4 months because we've been following up the patients now. And now they've been coming up for the 4th month follow-up. Not all of them, but at least around 40 to 50 patients have come. And those who had 6x6 vision had got the previous 6x6 vision. So in this number of patients, around 56 patients, that is 80%, had this clinical features had subsided and was reduced and come back to normal. And another 12 patients, it neither reduced nor deteriorated in these people. And 2 patients among the 70, their condition deteriorated. Conclusion, early diagnosis and intervention has resulted in better prognosis and improvement in ocular complaints. In patients with delay in diagnosis or intervention led to intracranial spread, resulted in loss of vision for whom destructive ocular surgeries are performed to contain the further spread. TRAM is a safe and effective modality between the mortality associated in post-COVID ROCM patients. And also it further avoids the patient from undergoing disfiguring surgeries like exenteration. Thank you.
What was the best improvement you have seen in the visual outcome from which stage to which?
So, ma'am, when we started taking these patients on their admission day onwards, we started documenting their vision from the first day onwards. So, in case the patient, if they had any fundus changes, like most of the patients had CREO in posterior segment, we did not include that set of patients in our study, even though some of them did receive TAMP. So, in our 70 patients, we took patients whose visual acuity started dropping, like when if they had 6/6, 6/9, if it started dropping by around 2 to 3, and patients who had 6/6, we've seen after around 3 to 4 months follow-up, they have regained the same vision. And in case they had a drop in vision or if the extraocular movement restriction, when it was starting, that's when we started giving tram for these patients.
So, Dr. Shivana, sir.
No, madam. Next presenter.
Thank you.
Doctor, I think all are done.
Ma'am, this is Anusha 106.
Okay.
I'll start, ma'am.
Yes, you can start.
Ma'am, is the screen visible, ma'am?
No.
Now, ma'am?
Yes.
Yeah, okay. Yeah. Good afternoon, everyone. Today I'm presenting a paper on orbital involvement as a predictor of mortality in COVID-associated mucormycosis. Paper number 1206. Purpose is to correlate the severity of orbital involvement at the time of presentation with mortality in patients with COVID-associated mucormycosis. Introduction. In the pandemic of COVID-19 past infection, India experienced a surge of rhino-orbital cerebral mucormycosis, a dreadful fungal infection. It is considered as a rare invasive fungal infection caused by plasmomycetes, fungi involving immunocompromised patients. Predisposing factors in development were diabetes mellitus with or without ketoacidosis, pharmacological immunosuppression, mainly steroids, organ and hematopoietic stem cell transplantation, prolonged ICU stay, and on patients on oxygen support for a long time. The route of spread being from nasal cavity to paranasal cavity to medial orbital wall to the nasal lacrimal duct, orbital apex, and intracranial spread to cavernous sinus. It can be divided into 3 subtypes: paranasal, rhino-orbital, rhino-orbital. Common symptoms include facial pain, proptosis, amaurosis, palatal and nasal ulcer with necrosis, classically seen as dark patch. Epistasis, headache, numbness, and orbital cellulitis are also present. Orbital involvement occurs when the infection invades the orbital wall from the paranasal sinuses. Symptoms include pain, chemosis, vision loss, proptosis, ophthalmoplegia. Ophthalmoplegia arises from infection of the muscles and orbital space or when the 3rd, 4th, and 6th cranial nerves are affected. Methodology, a retrospective observation study conducted at our tertiary care center between May 1st, 2021 to June 30th, 2021. All clinically, microbiologically, or radiologically confirmed cases of COVID-19 associated mucormycosis patients were subjected to detailed history, general systemic examination, ocular examination, including ocular involvement. Retrospective details of patients who died in ROCM were analyzed for ocular involvement at the time of presentation. Patients were categorized into stages based on signs and symptoms proposed by Hanover et al. A quick brush through for the stages. Stage 1, involvement of nasal mucosa. Symptoms being nasal stuffiness, discharge, foul smell, epistasis. Stage 2 was involvement of paranasal sinuses. Symptoms of stage 1 were facial pain, edema, and dental pain. For ocular involvement being stage 3, it was divided into 3A, 3B, 3C, and 3D. 3A was nasolacrimal duct, medial orbit, vision unaffected. Orbital diffuse involvement and vision unaffected. Stage 3C, central retinal artery occlusion or ophthalmic, superior ophthalmic vein thrombosis, involvement of superior orbital fissure, inferior orbital fissure, apex, and loss of vision. Bilateral orbital involvement being stage 3D. Symptoms included in stage 1 and stage 2, plus pain in eye, proptosis, ptosis, diplopia, loss of vision, infraorbital and facial V1 and V2 nerve anesthesia. Stage 4 being involvement of CNS. Result: a total of 429 COVID-associated mucormycosis patients were considered in the study. A total of 122 deaths occurred during the study period, in which 83 patients were COVID positive at the time and 33 were post-COVID recovery. Among them, 87, which includes 71%, were males and 35, which is 29%, were females. When we consider the total death, stage 30 patients belong to stage 1 and 2 with nasal mucosa and paranasal sinus involvement at the time of presentation. 36 belong to stage 3A, 3B, and 36 involved to stage 3C and 3D, and 20 belong to stage 4. But when we compare number of deaths with within the stages, stage 1 and 2, which is nasal and parasinus involvement, had total of 179 patients, out of which there was only 30 deaths, taking it up to 16.7% as death. Whereas in stage 3A and 3B, where vision was intact, 82 patients, of total 82 patients, 36 deaths were recorded, which is 43.9%. In stage 3 and 3D, where vision was involved, out of 110 patients, 36 deaths occurred, which makes up to 32.72%. Stage 4 was 38 of total patients, and out of which 20 deaths occurred, which was 52.6%. Conclusion: ocular involvement is common in patients suffering from mucormycosis. Majority of patients in the study belong to stage 3 of the disease. CNS involvement further increased the mortality rate. Knowing the severity of orbital mucormycosis will surely aid in the early management, surgical intervention in order to slow down the prognosis of the disease, also to possibly avoid mortality in patients with COVID-associated mucormycosis. Thank you.
All are done with present.
Yes, doctor.
Dr. Anna's 2 presentations are left.
But she is not there, ma'am.
Okay.
Doctor, can we end the session?
It's time up. You can end the session.
Okay, doctor.
Right.
Thank you, ma'am. Thank you, sir.